As a concept, the idea that members who take medications sort of as the physician intended, which we call adherence, uh, does lead to, one would think, lower healthcare spending eventually. And that's through better disease control, which relates to sort of lower hospitalization rates for a lot of conditions and elements like that. I think the challenge comes in with the existing literature. A lot of that's quite old, and we're talking about decade to 2 decades old. That's a very different landscape when it comes to medication adherence. We're talking about adherence rates at the population level with some studies that are like 50%, and that is markedly lower than adherence even in commercial, even in Medicaid anymore. Medicaid often exceeds 50%, right? And so you're thinking about who are those members who are not adherent when those older studies were done. Also, the methods that were used for those older studies don't account for common sources of bias. You're talking about ways in which adherence is defined, which is very different than, for example, Medicare does through STARS. And so all of this combines together to result in a different population over a different period of time using different measures. And so when we're really trying to quantify at the member level, what is this member's expected medical savings going to be, the existing literature, I would argue, isn't sufficient for that. And so managed care organizations can use integrated medical and pharmacy data if they have it to assess for themselves, for their own populations, what is the relationship between improvements in medication adherence and future reductions in healthcare spending. Ideally, you would want to do this over a 1-year period for contract reasons or other considerations. You would hope that there are some short-term results. We've shown with our data that there are. So we've measured this using the entire Prime membership that we have integrated pharmacy and medical claims on, which is about 16, 17 million people. And we've shown that there is a relationship between improvements in medication adherence and reductions in healthcare spending. Certainly can show that for commercial using recent data. Medicare gets a little bit fuzzier, but we can still show it for Medicare pre-COVID. COVID kind of mucks this up a little bit. But you can certainly see it in the data. Questions around sort of where can you get the greatest returns on investment are quite apt in this area. So one thing that we've seen with our data, which is pretty interesting, you can kind of divide the quality measures that we've used into a couple of different areas. I'd say one is mental health generally, the other is cardiovascular generally, and then you've got sort of an other category, which is like asthma with the measures that we've looked at. But we don't have a whole lot of measures in that area that we've used for our data. You actually see quite a bit of return from mental health. Interestingly, within the older adult population, using a somewhat, I don't want to say crude, but somewhat sort of pragmatic measure of antidepressant adherence, trying to apply the same PDC-80 method to depression, which has limitations but has some practical utility. We see that if you can get a member above 80%, that results in over $1,000 worth of savings. And so that's not within STARS, right? That is not something that would necessarily be on the desk of somebody who's thinking about how do I maximize my quality bonus payments. But if you think about the relationship between depression improvement, better control over other disease states because the member has more motivation to do so, direct relationship between that and reductions in hospitalizations and ED visits, then there's some real logic there. Within the commercial population, we see a lot of return from antipsychotics, for example. Much smaller population, of course, but you can clearly imagine clinically how taking an antipsychotic medication as intended is going to result in meaningful and somewhat short-term improvements in health that will manifest themselves in reduction in healthcare spending. Looking at that cardiovascular medication set, one thing you actually do see is a relationship between improvements in adherence for hypertensive medications and reductions in healthcare spending. The interesting thing with this is that if you look at just the renin-angiotensin system antagonists alone, sort of carve those out from other antihypertensives, you don't see as much relationship with that category, which is relevant because obviously that's what the Medicare Part D measure is built around, and but PQA has approved. We have a measure that we use that's a roll-up over a whole range of antihypertensive classes, and we apply it similar to the diabetes all-class medication where you need to be exposed to at least one in a given day. And we can show that for that measure, which includes not only members with hypertension, but you're talking about things like heart failure, other sort of cardiovascular condition, post-MI, right? That you do end up seeing a meaningful relationship between improvements in adherence and reductions in healthcare spending. So some of that might be due to the complexity of the cardiovascular disease states that the broader set of antihypertensive medications are used for, which drives that. But we do see a relationship between that antihypertensive class generally and reductions in healthcare spending that I think resonates clinically in addition to sort of being relevant statistically.